Hi, Simon Smale, GI.healthcare. I'm going to talk about drug treatment of irritable bowel syndrome today. To kick off, I would start by saying that we should use drugs in irritable bowel syndrome to treat specific symptoms, and they should be targeted at specific symptoms. So diarrhea needs an antidiarrheal, pain needs a painkiller, and so on. In general, drugs used in irritable bowel syndrome have a 1 in 4 to 1 in 5 chance of giving a patient a benefit, any particular drug, and they have roughly a 1 in 8 chance of giving a side effect. Now, they may not seem like great odds, but actually they're quite good odds for drug treatments in general. The important thing to note, however, is that irritable bowel syndrome generally doesn't kill people, and therefore a side effect in 1 in 8 may seem like an expensive cost for a condition that is not shortening life. However, I would argue that irritable bowel syndrome can have a massive impact on people's quality of life, and that in itself can have impacts on people's long-term well-being and health. I'll go back there. So broadly, the drugs fall into 3 categories. They can affect sensitivity, motility and stool consistency, that's how quickly the stool goes through the gut, and nervous processing. And very often the drugs have effects in more than one of those categories. So in terms of prescribing, the NICE guidance says that we should, for those with pain, consider prescribing antispasmodics, hopefully to reduce abdominal pain. And you can buy many of those over the counter, so things like Buscopan, Mebeverin, otherwise known as Colofac, can be bought over the counter in any pharmacist. Loperamide, likewise, is an antidiarrheal, otherwise known as Imodium, good for diarrhea. And laxatives can also be bought over the counter, and typically I'd recommend using something like Movicol or Laxido, which simply increase the amount of water retained in the gut. It is suggested in the NICE guidance that people shouldn't use lactulose because that may exacerbate abdominal pain and bloating, and the reason for that is, in short, because it's a FODMAP. So laxatives don't always work for everybody, and before moving to this drug linaclotide that I'm about to talk about, I would suggest that people try and establish themselves on a regular dose of laxatives. So you, rather than waiting till you're constipated, taking the maximum dose and then getting diarrhea and then not taking laxatives for a week and then getting constipated and then getting diarrhea again after a big dose of laxatives, you're better to try and establish yourself on a regular dose in order to keep your bowels on a firm consistency or an even consistency and frequency. And you might do that by taking a regular dose, maybe increasing the dose if you know you're doing something that's likely to exacerbate your constipation. But if that doesn't work, then the NICE guidance says consider linaclotide if they have had optimal or maximum tolerated doses of previous laxatives from different classes and they have not helped, and that people should have had constipation for at least 12 months. And that's essentially because linaclotide is quite a potent medication. And the NICE guidance says that people on linaclotide should be followed up after 3 months, although that's not in the current climate always possible. In terms of other pharmacological therapy, consider tricyclic antidepressants. Now, I tend to use these in people who've got diarrhea predominance because they tend to exacerbate constipation, but they're also good for pain. And it also says that you might consider SSRIs in people where tricyclics have failed. In general, a dose of 5 to 10 milligrams is a good starting dose for amitriptyline, which is an old-fashioned tricyclic. And the doses don't need to go above 30 milligrams of amitriptyline, generally speaking. So follow-up for those is recommended in 4 weeks, and the reason for that is because they take 4 weeks to work. They often don't work in the first 2 or 3 weeks, but they may cause dry mouth and drowsiness in the first few days. It's worth bearing with that if you can, because often that gets better, and then by 4 to 6 weeks, people are beginning to feel the benefits. And then people should be reviewed every 6 to 12 months just to make sure they're not getting side effects from the drugs and that they still need them, because you don't want to be taking drugs if you don't still need them. And then there are a couple of other drugs which might be considered, which are somewhat more off-piste, probably best used in the hands of people with an interest in irritable bowel, so or gastroenterologists. So drugs impacting 5-HT receptors. So ondansetron is one drug that's been shown to be effective in diarrhea, particularly in people with nausea. It's originally designed as an anti-sickness drug, of course. Antihistamines might have a benefit, and that's currently undergoing clinical trials, as may mast cell stabilizers. Again, the best place to manifest that is in clinical trials. So there are other drugs, but I could go on endlessly. I'm going to talk next about probiotics and prebiotics. I look forward to seeing you in the next video, but thanks for your attention.